Okay, and now, since we talked about the special considerations, what is one special consideration in North Carolina that we would use for RSI? Because some agencies you have to have either two medics or EMT basic and a medic. Because that's how. Let me start over again. You have to have two. There's two people on the truck. One of them can be EMT basic, one of them a paramedic. But in North Carolina, you've got to have two medics on the scene before you can RSI. So I basically told you a little special consideration. So just a little scenario: if you have like a 20 kilogram, you got 20 kilogram patient, which that's only like 40 pounds. So I don't know why I picked that number for. But how much, say, ketamine would you want to give this patient? Yeah, give up 30 to 40 milligrams. And then what about Rocky Run? What would you want to, how much you want to give 20 kilograms?
20.
All right. Okay, next one. Of course, right here, I'm not really going to go through a couple of European cities that good. That is the Airway Protocol for North Carolina, 2017 edition. And it just talks about basically all your different airway stuff. So what could you give the patient if they started waking up, showing signs of tachycardia, or start trying to like debug the tube? What kind of medications would you want to give for that? Versed, or you can give one more. You can give fentanyl or something like that. That'll kind of sedate them a little bit. Then next, how do we know, like I talked a little bit earlier, how do we know where the ET tube is? Confirmation of end-tidal, make sure you get a waveform. Equal chest rise and fall with verified lung sounds, and you have epigastric sounds. And of course, right here is your failed airway protocol. North Carolina, the OEMS states the failed airway exists when there's a failure to perform gas exchange in a patient that cannot do so on their own. And right here, this is probably pretty blurry, but that shows what you would do if you track, because up here it says you cannot have more than 3 attempts or no more than 3 attempts total to try to intubate somebody. And just go back to your basics, your BVM and your oral adjunct or oral nasal adjuncts for your oxygenation that way. All right, so now we're going to go ahead and get into the skills part of our lecture now. And so we're going to be utilizing a bag valve mask. We got different types of laryngoscope blades. We got Miller blades. We got Mac blades. We got stylets and doogies right here to help with the process of the intubation. And we've got our blind insertion airway devices such as iGels and King airways. And of course, we've got all over here all of our OPAs, NPAs, and all that stuff. So we'll just talk through how we're supposed to intubate a patient, and then I'll have a volunteer come up here, whoever wants to come up here and go through the process of intubating. Okay, so first you would want to go ahead and pre-oxygenate the patient while you're getting everything set up. So you either want to go ahead and start bagging them at 15 liters a minute, or if you think they can maintain 15 liters nasal cannula. So you do that, you go ahead and get your airway devices ready. You can go ahead and get your laryngoscope blades up and ready to go. And make sure the light works on it, because that'll be a crucial part in trying to determine where the vocal cords are. And also you want to go ahead and also, if I had a King Vision, I would put that as a second or third option. But for right now, we can use iGels or King Vision, or not King Vision, King LTD, and that will be our secondary. So next, while we're ventilating the patient, we can always put an oral adjunct in. So we do that, and we go ahead and get everything ready, and then we go through the process of intubating this patient. We can go ahead and size our tube. So I'd say maybe 7.5, probably good for an average adult patient. You always want to go ahead and kind of give the ETG a little curvature to make sure that because it'll be easier to go with the anatomy. And also you want to get your tube holder ready and your end-tidal capnography. You want to go ahead and plug that in. You also, I don't have one with me right now, but you always want to have your stethoscope ready. So when you place your tube, you can verify your absent epigastric and your normal breath sounds bilaterally. So after we get all this, after we talk through all this, who would want to come volunteer for this? Okay, Dr. Lees. All right. All right. All right. So what's the first thing that we want to do to our patient when we come up to a patient, see them in severe respiratory distress? Okay, you want to do your manual, your stabilization, your manual inline airway maneuvers. So either head tilt, chin lift, or something like that. Yeah. Okay, you want to, like as we talked about earlier, our oral axis, pharyngeal, and laryngeal axes. This is where this all comes into play. And now we all want to pre-oxygenate our patient. So, and what method are you using right there? Right there, he's using the C3 method, or CE method, however you want to call it. And we're pre-oxygenating our patient at this time. And then as soon as we get all of our stuff set up to oxygenate, then he is going to show us how the process of an endotracheal intubation. All right. So,
did you forget how to do this, Dr. D?
So at first we're going to make sure the handle and the blade fits. And okay.
Flip it the other way.
Then we want to go that way. There we go. There we go. That way. There we go. All right. So how do you think you'd want to hold the laryngoscope? All right. You kind of, yeah. Well, you want to use your non-dominant hand. So, like, yeah, there you go. Right. So you want to kind of finesse it in a way. Inside, kind of do it like a wine glass, but don't like tip it all the way up. Because if you go back on the teeth, and if you have to, you may want to lean onto the patient's head a little bit. And then you want to, as soon as you get the line in there and put it through, you want to go ahead and lift up a little bit without breaking their teeth, and you'll be able to see that at the time you'll be able to lift the epiglottis, and you'll be able to see two little white cords, which is the vocal cords.
I can see the back of this.
See the back of this. Very nice. Well, you got to lift up a little bit more. There, let me show you. Let me show you. This is. You ready to go? Lift up like that. Oh, this is not a good man. Yeah. Let's use this one. No,
I see some man control.
yeah, there's some man control. So you want to lift up like this without breaking your teeth, and you see the vocal cords, and you want to pass the cord right through the little V, the vocal cord.
Okay.
And a little tidbit, you always, every time you put the tube, or you put the laryngoscope in the mouth, that counts as 1 attempt. So, yeah, so don't hyperextend their neck, because that can cause more problems. And there it is. Okay, you see it? All right, so go ahead and get your tube ready, and go ahead and pass it through, but make sure don't go too far deep, because what could we encounter?
Right main stem.
Right main stem. Okay. Yeah, and make sure you maintain custody of the tube throughout the entire time. Why? Because
Mine too.
the reason why we maintain custody is because so we didn't. Let's see here. Here's our VBM right here.
I need this.
Oh, the syringe, let's see. Here's one. So there you go. And the syringe is always, syringe is always good to have to inflate the cuff and DT.
All 30 cc?
Just until you see the bubble blow out a little bit. Right there, there you go. That's about 10 cc's is about all you need.
It was.
Yep. So about 10, and then at this time you want to go ahead and secure it, and you want to make sure it's good. So guess you can use it that way. It will chastise them all after that, and then we'll go ahead and secure it while keeping custody of the tube. We want to go ahead and mark where our tube is and secure it like this. And then just don't want to clamp the tube down, and then just put it around their head like that. There we go. And then up through there. Then it's secured. So this, and then you just keep on. Now this time you don't have to maintain custody since the tube is already in place. So therefore, the oxygen saturation, he's able to maintain normal oxygen saturation.
If you find that you right main stemmed it, or it's not ventilating properly, would that merit backing it all the way out and starting a new attempt, or is it okay to just back it out a little and try again see if your placement's better?
You can always back it out just a little bit because you really don't want to extubate the patient unless there is something significantly wrong with the patient.
Okay.
So, just first off, I just go ahead and just
Back it out a little and
just
see if
back
you're
it
in
out
place
a little
now.
bit, yeah. All right. So, after, for what time are we at right now? What does it say on there?
12.
12. Okay. All right.
Plus the other video.
I think this concludes our skills presentation today. I think everybody for coming out, and I hope you all enjoy.